TopMedTalk.
Monty Mythen here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Hello, I'm Desiree Chappell, and this is TopMedTalk. We are here at the third Evidence-Based Perioperative Medicine USA Master's Course, a perioperative practicum. We're coming to you from the Baylor Medical Campus, the Charles Sammons Cancer Center, here in Dallas, Texas. Now I'm joined by Editor-in-Chief of TopMedTalk, Monty Mythen. Good morning, Monty.
Morning, Desiree.
How are you?
I'm good, actually. Lovely. We've had a great time the last couple of days.
We have had
been exhausting. Well, I think we've gone sort of whatever it's called, dawn to dusk, pushing out medical education, but it's been good.
So we have our special guest with us today, Jeroen Molinger, clinical medical exercise physiologist at Duke and a clinical medical exercise physiologist at Erasmus Medical Center. Well, Jeroen, thank you for joining us today.
Thank you for having us, yeah.
We're also joined by Dr. John Whittle, who is assistant professor of anesthesiology and critical care medicine at Duke, and he also holds an honorary position in perioperative medicine at the University College London. John, thank you for joining us.
Thanks for having me.
Yeah. Thank you guys for not only sitting down with us on TopMedTalk, but as Monty and I and Vicky were talking about earlier, we are the co-directors here at the EBPOM meeting. And when we were choosing, the people that we thought would really, again, impact our program, you guys were kind of at the top of the list for that, talking about the CPET stuff. So you had a session on Friday morning. Tell us about how that was.
It was good. I think, for all the English listeners and maybe Australian listeners and so on, perioperative CPET is a pretty familiar concept. And that's kind of borne out by the number of hospitals across the UK that have a perioperative CPET service. However, in the United States, it's almost completely novel and blinking of eyes. There's a few people who've heard of it. And they turned up to our session on Friday.
John, let's take a step back. Tell us what CPET is, because obviously it's not here in the U.S., and we have a lot of U.S. listeners.
So CPET, Cardiopulmonary Exercise Testing, it's an objective way of measuring aerobic exercise capacity. The original formulations were used mostly for diagnosis of unexplained exercise intolerance, especially if you imagine back in the 60s, prior to echocardiography, other tests, other imaging tests that were kind of possibly more prevalent now, particularly in the cardiology world and the pulmonology world. It was a good way of diagnosing limitation, cardiac, pulmonary. It's an integrated test. So, when you get on an exercise bike and you cycle against increasing resistance, then you stress, all your physiology. So right from the mitochondrion up to delivery of oxygen to the mitochondria, up to the macrocirculation, the heart, and then lung efficiency, so air, oxygen in, carbon dioxide out, simply put.
John, I know the majority of hospitals in the NHS have got a CPET service now. Do you know where it's gone to? Latest figures from poets from the society?
I think Denny was saying 70 to 80% last time I spoke.
Higher. Yeah.
70 to 80% of hospitals in the NHS have a CPET program.
Yeah.
Wow.
It's the largest users of CPET in the United Kingdom, and it doesn't really seem to exist here for perioperative use.
No.
Maybe very sporadic.
It's used here.
Yes.
Because the original training for cardiopulmonary exercise testing from the people from the UK was done in Southern California.
Correct.
So that's
and it's developed here,
and
right?
the original books all about it are all from
Wasserman.
Yeah, exactly.
Wasserman.
The Bible.
The Bible, 1960s, right? The original metabolic carts and using Douglas bags and so on here in the United States. And it is used clinically here.
Yeah. You've got equipment at Duke before you
We have equipment at Duke. The cardiologists do a few. Pulmonology, all the pulmonologists I've talked to at Duke had some exposure.
It might help, John, if we describe what happens back in the UK when you turn up to a pre-op clinic and someone says, we're just going to do your cardiopulmonary exercise test now?
Yeah, the process is simple. It takes about half an hour. You turn up, there's a brief questionnaire about whether we're going to make you fall off the bike, i.e., just a few medical questions about unstable angina and those sorts of things, things that maybe we don't want to stress.
Maybe relevant somehow. Yeah.
And then the test itself, basic height, weight, some spirometry to help produce some predicted values for respiratory parameters. And then you sit on the exercise bike, and the exercise bike is connected to what's called a metabolic cart. A metabolic cart actually does quite a few things that our anesthesiology and anaesthetist listeners will recognise, i.e. has a carbon dioxide measuring device, an oxygen measuring device, so paramagnetic oxygen analyzer and infrared oxygen analyzer, measures in and out carbon dioxide oxygen usage, a flow meter, a turbine, and we've probably all seen on some television advert at some point an athlete being exercise tested with the blue mask on, the little turbine in front of them.
Usually on a treadmill.
Normally, often on a treadmill. And in fact, we could talk about that a little bit more. But with this mask on, and they're being pushed to the limit, and there's a very suave and sophisticated exercise physiologist standing next to them.
Because they all are.
Because they all are.
I turn up.
So you turn up. You turn up. We're going to put a 12-lead ECG on you. We're going to put a saturation probe on you. We're going to put a blood pressure cuff on you. We're going to put this mask on with the turbine in front of you.
And the bike looks like an exercise bike in the gym. And the bike looks
like an exercise bike in the gym.
Gotcha.
So you sit on that. Next to it is a trolley with some measuring equipment on and a couple of computer screens. Then we just get you to sit there for a few minutes, get some basic baseline recordings, ECG, what your baseline breathing rate is, etc.
There are some videos on YouTube about this.
Actually, the UCL Centre for Anaesthesia have a series of CPET.
Yeah, we'll find those links and put them up.
Yeah.
So they take the test.
They take the test. So then they sit on the bike, and then you start pedalling against no resistance at first, a few minutes of that. And then over time, it's called an incremental test or a ramped test. And the resistance against which you pedal, the wattage, increases in a predictable ramp. So let's say 10 watts a minute, for example. And then you keep pedaling until you can't pedal anymore. Okay. Normally, that's volitional failure, right? I.e., you just can't pedal. The legs just don't turn.
Do it
You're too out of breath. And everyone has it.
So they fatigue out, right? Like the kid just can't do it anymore.
Yeah.
So then, so do you have a stretcher for them to go on?
Yeah, I mean, normally not needed. But yeah, I mean, in the clinical setting, we have all the equipment you'd need, the resuscitation equipment as needed. It's rarely needed.
A wheelchair to reel people out.
Yeah, correct.
Maybe good to point out is the safety of the test itself, because that's constantly being discussed, I think, right now. And the latest, I think there were some articles around it with doing 5,000 tests or so. I think there is an adverse effect around 0.5%.
Oh.
So that's, and then no lethal adverse effects. It's almost none.
Yeah, there's thousands of patients, several case series where the safety's been looked at, and really, I mean, no deaths in two of the big case series. I mean, people are worried about putting deconditioned patients on an exercise bike and pushing them to their limit, but we're all reasonable people, so we'll stop the test if we see anything adverse. And actually, there's some evidence that any, things that may happen, like an arrhythmia or patient feeling faint, actually, it's helpful to do that in a controlled environment prior to surgery, rather than find out on the operating table.
That's
when you're coding them.
The first one I saw with Paul Older in Australia. So a little team of us went down there to see him because he wanted to bring CPET to the UK. And the first test he showed us, having given us the whole spiel about nothing ever goes wrong.
Oh my gosh, she's serious.
Developed early ischemia and developed an arrhythmia. And he just stopped the test and said, "We know enough now." Said, so it was very informative. The patient didn't come to any harm. But what a great time to find that out.
No doubt.
Yeah.
Absolutely. Yeah. This idea of a spectrum of performance, right?
Yeah.
So I mentioned the elite athletes that have a time when they stop, and your most deconditioned patient will have a time when they stop. And it seems that the reasons that our deconditioned patients stop are different from the reasons that our elite athletes stop. And in fact, I'd say most commonly when we're doing our clinical tests, it's the legs are tired. They just can't push the pedals round anymore. They're often a bit out of breath and their heart rate's gone up a bit, but really just this legs failing. Whereas with our elite athletes, we find that they hit like this, extreme respiratory, peak of their respiratory function, peak of their cardiac function, out of breath, they're sweaty, And it's not so much their legs stop, they just really can't pedal anymore.
Yeah.
Yeah.
Just of my experiences I have with elite athletes and also with, for instance, elite marathon runners. If you look at just prior to finishing the marathon and you're an elite runner, they instantly crash. Mm-hmm. And also during our CPET testing, if you have an elite athlete doing the CPET, they crash afterwards. They go so far. And that is, I think, somewhat intriguing in the sense of how their phenotyping is so distinct different than, for instance, our unconditioned. It's not just an unconditioned phenotype based on a low anaerobic threshold, on a low Vo2 peak. There is far more in it. And what John and I try to somehow assess and to see what are those distinct differences and what could leave us more and learn us more in regard to being at risk, yes or no. And that's not only that the Vo2 or an anaerobic threshold itself. Mm-hmm. It's a little bit of a black box still, because we don't really know why. Why do you have to have a high Vo2 to be less at risk for complications after surgery? It's almost a no-brainer. Of course, you have to be fit for surgery, but why?
Yeah.
What is so distinct different being fit than being unconditioned?
Mm-hmm. Yeah, it's interesting. So, Jeroen, you perform these tests too, is that correct?
Yeah.
So, why do you guys use a bike and not a treadmill?
Good one. In the US, there are mainly the cardiologist is used to use treadmills over here instead of but they don't run. They walk with the Norton and the Bruce protocols. We're more eager to do the bike because it's more efficient. I think you have your ECG measurements are far more less. There's so much noise when you run and
signal
walk.
interference.
Yeah. And we see that the ability to walk efficiently is so different within people. And if you have some kind of issues with joints and knees or hips, etc., you cannot do your run or your walk, but you can do your bike stuff.
Yeah. I would say a fair amount of my patients would say there's no way they're getting on a bike. I'm sure this is something that every clinician comes up to you and says that.
In our cultures, everyone's ridden a bike.
Yeah.
So it's amazing that...
Oh, yeah.
So most people have, So it's the muscle memories that sometimes... I mean, we do sometimes find when we put a patient on who hasn't ridden a bike for 40 years that we have to kind of move their leg a little bit, and then they start. They just
push the knee.
They push the knee, and then off they go. Yeah. Almost everyone in Western culture has ridden a bike. I'm sure you're referring to the Sherpas living in the mountains.
We didn't think that one through.
Oh, so my goodness.
You'll hear it on some of the podcasts if you look up the Extreme Everest and they're talking about testing it.
Yes.
Cardiopulmonary exercise testing at altitude, the indigenous Sherpa population.
I've never seen a bike.
There's nowhere to put wheels.
Go down.
It's on a wheelbarrow. You're pulling.
Can I do this riding a donkey? Give me something to carry. But anyway, but it's almost everyone. It's very rare to find anyone who can't turn the wheels, isn't it?
Yeah, absolutely.
But still, we do a lot for our Premier Soccer players, for our marathon runners, etc. We still use a treadmill because you have to assess based on what they do in the sports itself. It's a little bit crazy to test a soccer player on a bike.
Yeah.
You can do it, for instance, just to be sure that you have your ECG signaling right, because we don't want to do the Vo2 peak, we just want to know if there's something different.
So on that subject, there are setups so you can test swimmers in a swimming pool.
Yeah.
Oh, wow.
You can test, there's some good stuff of cross-country skiers on these really wide treadmills, essentially, rolling roads, and they're skiing and having their test rowers on the rowing machine.
So with the Sherpas, you would get one of those incline walker, like the step machine?
Wasn't in the protocol. We didn't have...
Where the stairs just keep rotating around, they can just walk.
They learned. If you don't have to make the bike go down the road, you can learn to turn the pedals pretty quickly.
It's easier to teach them to ride a bike.
And there's also, in regard to testing, you have an average higher Vo2 peak or max with treadmill around 5 to 10%. So just testing somebody on the bike and testing somebody on the treadmill give you different kind of outcomes. The treadmill is for sure higher because you're using more muscles.
Okay, so you've done the test on the bike.
Yep.
You get these results. What do you tell the patient that day?
So the first thing we tell them, it's not a test, it's an assessment to help us with decision-making around surgery and to help with the discussion about how best to improve the safety of what we're doing. So that's the first clear thing that we always say. It's not a test, even though...
Did I pass or fail, Doc?
It's not a pass-fail test.
Yeah.
Okay? And it's really important to highlight that. Right?
Yeah, for sure.
So there's a whole bunch at the moment. So again, I'm going to shout out to POETS.
What does POETS stand
so Perioperative Exercise Testing and Training Society. So
yes. Double T. That's
Double T.
Double T.
Yeah, Double T. They have a website. It's Monty's brought it up. poets.co.uk. Double T. And they have recently set up the standards and guidelines for conducting cardiopulmonary exercise testing, as well as a mode to accreditation. So standardization is important in perioperative medicine. That's what we learnt every time we come to an EPOM conference. Yes. So we will analyze it according to the POETS criteria. Jeroen and I have our research interests, but actually for a clinical CPET, there's a whole bunch of data that has evidence behind it or relates to risk. So Jeroen's already mentioned a few of the parameters, and for those people who don't recognize the acronyms, so Vo2 Peak or Vo2 Max, you'll probably, if you ever do sport, you may have heard of Vo2 Max. They are subtly different. I'm not going to go into that too much, but it's essentially the highest amount of oxygen usage per minute, and we often normalize that to body weight. So mils a minute a kilo.
Actual body weight or?
Currently, use actual body weight. Yeah, good point.
Good question.
Good point.
Yeah. Maybe we should do relative on relative, because the thing is, we do it relative on, maybe we have to correct it for lean body mass itself, not the whole mass.
Yes.
Yeah.
But there's not an easy or reliable way currently to assess lean body mass.
No.
So we just do it to whole body weight. And that's an important point, and it's one I always bring up in the talk. So if you look at the highest ever recorded VO2s, so VO2 maxes, the highest ever has been in a rower. I believe it's still the highest ever. So Sir Matthew Pinsent.
How is he the highest?
Yeah, at least unless it's changed recently. But he had
peak, max, or AT.
Max.
Okay. Max.
Yeah, actually,
absolute.
He's interesting. Actually, in terms of his lactate physiology, but that's a different story. But
is he the one that's just gone back in the boat?
No, that's Cracknell.
Okay,
Cracknell. Yeah,
that's
wow!
40 years.
You are geeky. You guys are geeking out on this.
He's 40 years old already, I think.
Yeah. But this guy, anyway. The point of this really terrible anecdote is this guy has the highest absolute, oxygen consumption. But when you correct it for lean body mass, as in body mass, he's a heavy guy. He's 110 kilos. But then if you look at Bjorn Dali, who was a cross-country skier who was extremely successful in the late 90s, early 2000s, he corrected for body mass, had a peak or a max of 92, I think it was, mils a minute kilo. Yeah. So to give you an idea, maybe someone of his age at the time should have had about 30 or 40 to be fit. And our patients that come in on average in our clinic have a peak VO2 of about 16. So,
that's what I was going to say. What do you guys normally see?
So 16 is bad, unfit, deconditioned. But some patients, so this anaerobic threshold is the next thing. Some patients achieve anaerobic threshold.
Before you get to that bit, John, it's just like if you took a regular sort of 40, let's make them 50-year-old, exercising individuals, there's clear evidence of doing some proper activity and pushing this up. What would you expect them to come in at, roughly? 25, 30?
30, 35.
Okay, 35, yeah.
We had a 60-year-old guy in the other week who's a keen cyclist, and he achieved 47, which is good. I'd be pleased with 47.
And we are, of course, extremely well trained, so we practice what we preach.
So what is yours?
I'm around 50 right now.
Wow.
Last time I was tested, I was very fit, so I was in the 60s, but I'm definitely
Oh, my God. Now
he's
you're...
in his 40s, and you're above 40s, of course, but yeah.
A lady never releases her age.
But the discussion was, maybe, John, you can tell us what we also measured in our, call it, healthy colleagues right now.
Yeah, so
you put everybody on the bikes.
Yeah.
We're obsessive and evangelistic. So a lot of our residents, our trainees, have been getting on the bike at Duke, and we found out that residency is very bad for your aerobic fitness. We're sort of looking in the 20s to 30s for these.
These are the ones that tell you they're working out on a regular basis?
Absolutely. Yeah. Well, this is the other thing. So patients and residents turn out are the same in that a patient will come and tell you, I exercise regularly and I'm pretty fit. And then you objectively measure them and you find that's not true. That's the same with residents. And they remember being the soccer player that ran around the pitch at college, but they haven't noticed, because you don't really. They haven't noticed the decline since college.
But I can't tell you their split times for on a Concept 2 at level 10 for 10,000 K last week.
Exactly.
There are two sides on this story, because people think they train well. And if we ask them, what are you doing? I'm doing my running and do my body pump stuff and all. And if you're thinking, and my next question is, but how far do you go? Do you go to fatigue?
Yeah.
If you're doing 8 reps, is your 9th not possible? No, I'm always doing my 4, 8 reps.
Yeah.
And I always run my 5K.
Yeah.
And afterwards, I'm fine.
Yeah.
And
So
that's the
we're not
triggering what you're
maxing
seeing
out.
right now. You have to have some kind of triggering within your training to get your system somehow being supercompensated.
Yeah.
And I think just one, we don't train. Not enough, but not good enough in the sense of not efficiently. Yeah, exactly.
Yeah.
So this is another concept that we bang on about is exercise versus training. So certainly people who regularly exercise, people who move a certain amount as a population estimates over time, sure, they're going to live longer. Okay, so we are not discouraging people from going to the gym and doing their 20 minutes.
Absolutely.
But if you are training and you're trying to improve, then actually there's a loading aspect to that.
So if families listening, we can vouch for the fact that the concept 2 at home is very well used by the family. Okay, so when I row, I don't know if I'm doing it right, I try and do my 5Ks and my 10Ks, but in between each time, I'm pulling as hard as I can for a short period of time till I have to stop, if you see what I mean, and then I get back into the study. Is that helpful or is that wrong?
Yeah, all these things are in flux, right? Training patterns and so on that have been recommended have changed. So I remember in the 90s when I used to run and we were told about fartlek training, like this... is it Swedish?
Run between the lampposts, sprint between the lampposts.
Sprint between the lampposts, playing with speed. That's what fartlek is. Currently HIIT is the thing, isn't it? High intensity interval training. So in broad brushstrokes, you've got MICT, which is moderate intensity continual training. You have HIIT, which is high intensity interval training. And now coming in as the new contender for the prize is SIT, which is sprint interval training.
So for each K I'm rowing, that I feel as though I'm rowing it aerobically, but I'm pushing myself to what I believe is my best times. The last 150 metres I pull as hard as I can.
Yeah, so number one, that's probably very good for you. That challenge is great. Nothing wrong with that. I think if you are working out 3 times a week, let's say, the current evidence would probably support 2 high-intensity interval training sessions. So, for example, I have a Concept 2 at home, and so what I do is I do a warm-up, and then I'll be doing either 30 seconds, 1 minute, or 1 minute, 30-second sprint intervals with 3 to 5 minutes in between of just light rowing, and then I'll cool down for 10 minutes. And that twice a week, and then once a week I'll probably do what you do, a 5 or a 10K as a moderate intensity. And that is current levels of evidence. Jeroen can probably speak more to the sprint interval because it's his thing.
Yes, we're looking into right now an efficient way to get your VO2 up. And looking back in what kind of triggering do you have to trigger the system to get a high VO2 is just based on depletion of glycogen, intramuscular glycogen depletion. You can have depletion based on aerobic training, but that takes you a long time of 40, 45 minutes and so on.
We should probably remind people what glycogen is.
Intramuscular glycogen is a substrate bounded within the muscle and can be used instantaneously. It's a substrate which is profoundly used during sprints. And going back from that point of view, it's more likely to be your...
And it's carbohydrates.
Carbohydrates, sorry. Yeah.
Little packets of carbs hidden around your body so you can call
upon. The sugar. The sugar within your muscles was being used. And it can be used instantaneously. And the depletion of glycogen, of muscle sugar, gives rise to a whole kind of cascade of metabolic supercompensations right now. And
good ones or bad ones?
Good ones.
Good ones, okay, right. So
you feel them as bad, but, but in the end it will give you far more and higher VO2 based on that the depletion of glycogen, we really don't know. It's still a black box where your VO2 is getting up. One of the thoughts we have, it could be you can supercompensate on your glycogen itself. So afterwards, when you're drinking or eating again, that you're refueling your sugars within your muscles. And you're supercompensating, you have more sugars within the muscles, so you'll be ready for the next day to have even a higher amount of power you can produce.
And do we vary quite a lot in how we store it, irrespective of our training programs? Yeah. There are some people who get hangry. Yeah. They start carb craving, and other people don't feel
pointing
that.
Towards me.
Are they,
Thank you.
Is there anything like that?
Now, the thing is, to refuel or to load your muscle with carbohydrates is also a condition.
Okay.
So what we tend to measuring in our ICU patients or in our athletes, you have your normal day-by-day variation in low and high glycogen content. And it's not that you have if you're measuring a low glycogen content, then you just have to eat your carbs and then it's all up again. No, it's the supercompensation that's a part of the being fit. So, for instance, another athletes can use being depleted, and after the depletion period, you can stack your carbohydrates and get a supercompensation of cardioglycogen. But the thing is, we really don't know why the VO2 is going up. One of the other thoughts we have is that your circulating volume, blood volume, goes up in 3 to 4 or 5 weeks. We did a pilot program where we used our spin interval for the Whittle patients prior to surgery.
I pause you there for 1 second, because again, this is all about me. So before I do my training, should I try and starve myself so I can deplete my glycogen stores more rapidly, so it's easier for me? Because I like...
It depends. No, it depends. If you can do so... Yeah, if you want it's your primary goal to have a higher VO2 in a longer period, yes.
Okay.
If you want to be the very best in your performance day, no, because you have a lower performance.
No, I want to get the greatest benefit for the least effort. There's a lot of people out there with me on this.
I was just going to say, I'm digging what you're doing.
Then for sure, I think we should do a prior fasting period.
Okay, yeah.
So
do the workout first thing in the morning, for example, and then have breakfast.
Yep.
Okay.
Afterwards,
I think that's right.
Sorry, you were taking us somewhere more interesting. This would cost a fortune, this consult. So,
because looking into it, the only intervention we did in our pre-Whittle patients, it was a total intervention of only 2 minutes.
So these are patients having their pancreas removed.
So we did our CPET testing. We had only 4 or 5 weeks prior to surgery, and we did them in the spin interval training regime, which was the 3 times a week, 2 times 20 seconds. That's a total of 2 minutes intervention.
Wow.
A week.
Yeah. Write this down.
That's it?
Yeah.
That's it. Yeah. And we saw on average an increase around 1.5 mets.
What do you have to do for the 20 seconds again? Someone writes down.
Oh, it's just it looks easy, but maybe John can, because John right now is not an early adapter, but he's doing his third one today.
We've done 3 days in a row.
What do you do?
So the clinical application he did was 20 seconds 2 times at just maximal 20 seconds.
Of what?
Cycling on a bike. What we did...
20 seconds of go.
With a strict kind of torque, with the resistance fixed.
Okay. So fixed resistance. And again, we're not going to get into the weeds of this, but the way you prescribe the resistance is based on a
body weight.
A body weight, exactly.
Okay. Wow. So really hard to turn the crank, 20 seconds, go.
Yeah, essentially. There's a fixed resistance. So instead of being a prescribed wattage, it's fixed resistance, and you go.
The harder you go, the more wattage you give.
And so what did we do? So I tried it for the first time on Friday, and I did think I was going to die.
3 times.
Yeah, 3 times. 3 times. So we 30 seconds, all out, stop, rest 3 minutes, 30 seconds, rest 3 minutes, 30 seconds. And you can feel for hours. We actually were measuring, we were using, because we are geeks, and we bought a bioimpedance cardiac output monitor with us.
Of course.
To the conference, in the hotel. We were measuring. And you could see profound cardiovascular changes.
Directly, acutely,
immediately and acutely. Massive drop-off in peripheral resistance, sustained increase in cardiac output.
It sounds like that could kill me. Okay,
yeah.
If I did it out of the blue. As opposed to the cardiopulmonary exercise, it sounds as though I could kill myself doing that.
So
yes and no, because it is the hemodynamic changes John is describing is in a fit person right now. Looking back in a sedentary person, the thing is, because it's such a major hit for the peripheral muscle, that's the major limiting factor in those populations, not the central limiting factors John has.
Well.
So yesterday I presented in the session that you chaired, and there was a big difference in limitation in a sedentary, untrained individual versus a trained individual, and I would probably just put myself on the trained individual end. So a sedentary, untrained individual is limited by their mitochondrial capacity to use oxygen.
Right.
A trained individual is limited by centrally for cardiac output and also volitional as well.
Yeah.
Heart-lung grit.
Heart-lung grit for a trained, and untrained is just how efficient
the energy units in your cells.
Correct. So the hypothesis, and this is research and not confirmed, but the hypothesis is that in the untrained individual, actually the metabolic stimulus is high, while, and Jeroen was doing it on Whipple's patients, and with a lower dose, you don't see the same systemic collapse that you get with someone like me. So,
and that's fine, because what we want to know is we want to have depletion in the peripheral muscle. Right. So if you just make a video of John doing the sprint versus an 85-year-old pre-Whipple patient, it's distinct different.
Yeah.
But what happens in the patient is still the depletion and the triggering in the system to get a higher VO2.
So what did you hear, or what was the outcomes that the study that you're looking at? Because you never.
The thing was, we didn't do an afterwards, but what we were able to do, what we know from the evidence is, if you are able to increase the VO2 with 1 MET, that 1 MET is a metabolic equivalent, so is 3.5 mils per millimeter per kilogram muscle mass itself. That makes almost 15% decrease in mortality. So
1.5?
1.5, yeah. So that's yeah. And that was our goal. Are we able, because that's a significant kind of decrease of mortality in the pre-op, doing it in a window from 4 or 5 weeks. So we can train what we want, but in our perioperative period, we have a deadline. We have a specific period. So to be the most efficient way of training is vital for us to switch for. So I think that's more or less our part of searching for the Holy Grail, dissecting VO2. Why is VO2 so important? And we see that it's not just VO2. It's far more the complete phenotyping and the metabolic phenotyping of a patient.
So the patient goes in, they have their assessment, you get the information that you need. What do you do with it then?
Okay, so the uses of CPET are essentially risk stratification. So there's a whole bunch of data out there associating various peak VO2s, anaerobic thresholds with outcome after different types of surgery. So number one, we use it as a risk stratification tool. Number two, you then use the other data alongside the risk stratification as a clinical decision-making aid or clinical decision-making tool, which of course shares into the shared decision-making piece. So you share it with the surgeon, share it with the patient, and undergo an informed discussion about limitation. Number four, we use it for helping to prescribe optimization. So if we see cardiac limitation, alterations in heart rate dynamics, evidence of ischemia, or someone we may want to alter the medications the patient's on, we may want to refer on to a specialist. So we use it as a diagnostic tool. And then finally, and the emerging use is to prescribe prehabilitation programs and use it as a basis for identifying who may benefit and also, in many cases, prescribing intensity for that prehabilitation.
But if you want to know more about cardiopulmonary exercise testing, almost all of the EBPOM meetings has an opportunity to be exposed to it. So if you go onto ebpom.org, the next actual POET CPET course is the 20th. Well, that's how long it's been going for now. Is in London on May the 15th and 16th. The 21st is June 30th, July 1st. And then the 22nd is on November 19th and 20th. But if you also want to come to any of the evidence-based perioperative medicine meetings, you'll get a chance to be exposed to it. Now, our next USA meeting is coming up in Chicago in September. Do you think we're ready to have a POET CPET course in the USA?
Yeah, I think so. So we're hoping either next meeting or meeting after to run a POET's course.
Because I think the level of interest has risen to a point. Now, it was a slow start in the UK back in the day. 5 or 6 people turned up, and now everyone sells out. It's the level of interest it's grown to.
I was going to ask when we first started, when we first started the conversation, in the UK, how many years did it take for it to really come to be adopted? I mean...
probably about 10 for it to get reasonable traction. There are a few early centres. We weren't the first centre, but we were one of the first. So I've been thinking York and Torbay were earlier than us. We went out, and Paul Older came on sabbatical to us. So Paul Older's recognised as a sort of the father of preoperative cardiopulmonary exercise testing. He's an intensive care physician anaesthesia in Australia. Retired now, but still you'll see him associated with a lot of the cardiopulmonary exercise testing. And then it sort of reached an inflection point, and then by about 4 or 5 years ago, it went to the majority of hospitals, and now it's gone almost universal. So that's typical, 17 to 20 years is the sort of adoption cycle for something.
Just some of the discussions we have here, because it's obviously very early in the process in the United States, about limitations and why and who what are very similar to the ones that were had in the UK early on. So that's the type of thing we can discuss at these courses as well.
Absolutely.
The business case is easy.
Oh, yeah.
That's really, really easy. It then comes down to, as we often talked about, is in the UK, more work is just more work. It's not more money. So if you're going to take the burden of other single organ specialist doctors and do a holistic evaluation more cost effectively, it's very popular in the health system. If you have a lot of people who are living off preoperative evaluations of organ by organ, then they're a bit grumpy with you.
Yeah, that's fair.
Yeah, that's very fair. Oh, I'm glad we've had this conversation about CPET because I don't think we've ever had this deep of a dive into it. So thank you guys very much for that.
Absolutely. Thank you so much for having us.
Thank you.
Yeah.
TopMedTalk.
Hi, TopMedTalk friends. I wanted to let you know that we have some very exciting news. EBPOM London 2020 is on. We will be having the meeting. It will be the original dates, June 30th through July 2nd. We're going to mix it up a little bit. So be sure that you visit our website at ebpom.org. That's ebpom.org. You'll get more details. We are going to be offering content on demand content as well as live content. All the most amazing speakers that you ever hear at all of our EBPOM events. So that's super exciting. It's only 150 pounds, and you will have access to all of our content for that. So be sure to check us out again, ebpom.org. We're super excited about everything we have to offer this year. All of our same speakers, all of the same quality that you would normally get at a live meeting in person, but you can stay in your jammies. So be sure to check us out. Thanks so much for listening, and hopefully we will see you at Live from London, EBPOM 2020.